And now we're gonna have Dr. Shizuka Ko, who's gonna coming here. Is a wonderful cornea specialist from Osaka, Japan, who's gonna tell us about RGPs and their impact on progression.
Okay. Thank you, Sonal, for the kind of introduction. Good afternoon, everybody. This is Shizuka Ko from Osaka University, Japan. It is my great honor to be invited to here to give a talk today. My talk is about do corneal RGPs have an impact on progression of corneal ectasia. As you know, keratoconus is a progressive corneal ectasia with onset typically in the second decade of life. It is general body bilaterally, although often asymmetrically. It is characterized by steepening, distortion, and apical thinning of the cornea, leading to visual deterioration in result of irregular corneal stigmatism. As you know, it is reported to be frequent, rare disease. This is the management for keratoconus from the recent review paper. Although there are several options for management for keratoconus, contact lenses are still major options for keratoconus. Of course, there are square lenses and hybrid lenses, but rigid gas permeable contact lenses, actually corneal GP, are also widely used. So today, I'd like to talk about the to solve the two big misses. So far, there have been a kind of misses. So number one, do corneal GP lenses impact keratoconus progression? And number two, how about refractive effect on posterior surface? Is it do they only have influence on only on anterior surface? I like to focus on these two topics. So according to the global consensus on keratoconus and ectatic disease, actually it states that corneal GP lens does not slow or halt keratoconus progression. It is just only for the visual rehabilitation. But so far, there are a number of controversial papers. So the pathogenesis of keratoconus reported to be somewhat it have corneal GP lens introduced inflammation, and some paper reported that corneal GP lens could increase in the sinus corneal thickness, or some paper reported that corneal GP lens actually because of the corneal GP lens wear, corneal epithelial and stromal can be thinning. These are all controversial. So we are very interested in actually, so how about the chronological corneal changes associated with long-term corneal GP lens wear or not? So we compare the two groups. Actually, one group with long-term GP lens wear, and one group without any lens. So we evaluated 3 parameters. So we using the Behring ABCD progression display from Pentacam. So A for anterior surface, B for back posterior surface, so C for corneal thickness, A for anterior surface radius, B for posterior surface radius, and C for sinus corneal thickness point. Sinus actually corneal thickness. So what we found is between these two groups, actually there was no difference on keratoconus progression. But actually we found the better corrected distance visual acuity was achieved with the corneal GP lens wear. So we concluded there is no actually impact on keratoconus progression due to the corneal GP lens wear, but corneal GP lens wear can actually improve the quality of vision and quality of life in keratoconus patients. You know, this is actually representative wavefront map from the keratoconus. It is characterized by coma aberrations. you can see if you see the simulated retinal image, it actually, it is like comet-like image. But once this patient actually wore the corneal GP lens, it can correct irregular corneal astigmatism from the anterior corneal surface. But we don't know how about the impact on posterior corneal surface. So this is a known fact. Actually, corneal GP lens for keratoconus it is very important for visual rehabilitation, and it can improve visual performance. But refractive effect on posterior corneal surfaces is unknown. So these are, as you know, these are the three major fitting approaches of corneal GP lens for keratoconus: apical touch, apical clearance, and three-point touch. In apical touch fitting, lens sharing is actually on the apical onto the apex, and for the apical clearance, lens bearing is actually directed to the placentral part of the cornea. Actually, three-point touch is somewhere between these apical touch and apical clearance methods. In my clinic, actually, most of the keratoconus patients are actually fitted with apical touch or three-point touch. So you know, anterior segment OCT is a very fancy tool. It can image both corneal surfaces, even in eyes with corneal GP lens. Shown here is the two images with without lens and with GP lens from the same patient. It can clearly actually show the it can analyze the corneal map even with the lens. So let me share with you the Fourier analysis. So this is a representative Fourier analysis from the keratoconus patient. But these actually maps are only from the posterior corneal surface, because OCT can actually quantify both anterior and posterior corneal surface. So on the left side, on the left, there is the original map from the posterior corneal surface, and refractive power can be separated into four powers: spherical, regular astigmatism, and asymmetry, and higher order irregularity. Actually, asymmetry and higher order irregularity are the irregular astigmatism, which cannot be corrected with glasses. So this is a map from without no lens. But once this patient wore the GP lens, you can see the reduction in the Fourier map. Still, he have actually a kind of irregular astigmatism. Actually, you can see the decrease in the color. When I show the numerical data, there is a significant decrease in spherical, regular astigmatism and asymmetry power from the posterior corneal surface. So we also investigate how the posterior corneal surface flattening can is correlate with biomechanics. So these images are actually obtained with Corbis ST from Oculus. So there are two commercially available machines which can assess the corneal biomechanics. You know, you can see the kind of in keratoconic eyes, you can see that actually the eye can be easily deformed. So in Corbis ST actually provides so many parameters. Let me actually share with only the focus several parameters. So from these parameters from Corbis, there are several important parameters. Let me show you. So softer cornea can deform easily. So DA ratio is actually calculated from the deformation ratio between the central area and peripheral area. Actually, softer cornea actually shows a high number in DA ratio. And as you know, softer cornea, like keratoconus, has a smaller radius. So that means inverse radius is higher. And if we actually calculated integrated of the inverse radius, this number will be higher. So softer cornea shows the integrated radius higher. ARTH is actually, it is calculated from the corneal profile, so we can skip it. And SPA1, this, it is called as stiffness parameter A1. This is actually calculated calculated by the power, displacement force between the air pulse and biomechanical IOP. So basically, actually, softer cornea shows the lower SPA1. And the left side, you can see the CBI. This is the Collis biomechanical index. This can be calculated from all these severe parameters. It is kind of a comprehensive parameter. It is a range from 0 to 1. 1 means actually softer cornea. So we investigate the correlation between the difference in spherical power with contact lens wear, and also x-axis shows the parameter from the curves. What we found is corneal biomechanical property, actually all the parameters actually correlated with the posterior corneal flattening by corneal GP lens. So actually, it means posterior corneal surface flattening during corneal GP lens wear is greater in the severe keratoconus. So let me summarize. So long-term corneal GP lens wear have no effect on keratoconus progression. And number 2, corneal GP lens can correct the posterior spherical component and corneal irregular astigmatism due to biomechanical stress strain caused by the corneal GP lens. Not working. Not working. Anyway, it's okay. For some reason, it's okay. Okay, thank you. Thank you.
That's fantastic. Do we have any questions for Dr. Ko? So that was really interesting because my contact lens specialists do believe that it does, that hard contact lenses do make keratoconus progress. So this is interesting news. Have you looked at scleral lenses too?
Thank you for the question. Actually, unfortunately, believe it or not, scleral lenses are not approved in Japan. So I have no experience with the scleral lenses. But as you mentioned, actually, so previously, some people actually believe that corneal GP lens actually can actually progress keratoconus. But I believe this is not true right now.
You think it's just that people who have worse keratoconus are the ones that tend to wear? Because her theory was that when you use the suction to pull it, you know, the RGP or the scleral lenses off, you might be causing some changes in the biomechanics and causing, so that's interesting to know. So thank you.
Thank you.